The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, with Jeremy Hendrick, child psychiatrist. So, Jeremy, your training is fascinating because you're one of the triple board people. You are a pediatrician, you are a psychiatrist, you are a child psychiatrist. You're a lot of things.
Yeah, I entered training not really exactly knowing what I wanted to do, and I guess that's what ended up happening. But I'm really grateful for the training. I am definitely first and foremost a psychiatrist, but I keep my peds boards up to date and love interacting with my pediatric colleagues, just because I think that training gives me a perspective that gives a slightly more holistic view of managing these kids. So I'm really glad I did it.
No, absolutely. And we're glad you did too. We wanted to continue our conversation about advanced treatment of mood disorders. Before we do, have you developed any disclosures, anything you need to share with us?
I have nothing to disclose to you today.
Is there anything you wanted to share about otherwise? Because I don't know that, who helps the helper?
That's a great question. That is a great question. You're kind of blowing my mind with these questions, Paul.
All right, let's dive in. This week, we wanted to talk about some comorbid issues because I think that's something that's so incredibly vital that we understand. It's probably a good idea that we put those in front of our mind. You game?
You bet. I think this is such an important topic and something we run across all the time when we talk to our pediatric colleagues.
Terrific. So I'm just asking the obvious question, why should I care about comorbid conditions?
I wish diagnoses just happened in isolation, but, it turns out that brains are a little bit more complex than that. And I will say probably the biggest reason, has to do with whether or not your patient's getting better. And so often we focus on the idea that we need to switch a medication or switch an intervention because it's not working and it's just a matter of finding the right medication, when sometimes we may have glossed over what we're actually treating in the first place. And so many of these diagnoses in mental health, specifically in kids and adolescents, have symptom complexes that overlap that oftentimes we find ourselves treating the wrong condition. And so understanding and making sure we feel good about what we're treating is, I think, a really important first step.
This is a little bit of a side comment, but I was thinking as we were talking last week that it's interesting that we don't necessarily have marked pathways for the treatment of pediatric psychiatric disorders, given that the diagnoses themselves are often based on a checklist.
Yeah.
That we have a roadmap to make the diagnosis, but not necessarily to treat it. But the thing that I think that we absolutely have to remember in the process is that the diagnosis is not the thing. It's taking care of the child that's the thing. And it's important that we keep an open mind, as you just mentioned, about other stuff.
You bet.
All right, let's talk about some of the overlap diagnoses we ought to think about. How about just thinking about depression and anxiety at the same time?
Yeah, this is such a common one. And part of it is because, when you look at depression and the state depression can place a patient into, angst and worry and anxiety are absolutely part of the picture. And while those may not necessarily be core diagnostic symptoms per diagnostic statistical manual, you can just think of any of your depressed patients and the number of them that have kind of an angsty, worried, perseverative nature is pretty significant. That said, you also get quite a few kids that, you treat their depression and that anxiety tends to get a little bit better, as you treat the depression, and vice versa. If they're an anxious kid, treating their anxiety helps them get over just the burden of feeling that way and some of those depressed feelings. But really, you have to look at what the primary driver is of that. There are other kids for whom, they may be struggling with anxiety and depression, and you may assume that they're one of these kind of angsty, depressed kids. But when you really dive into treating one of those conditions, the other actually kind of remains there and present. And so, you absolutely can have kids that have what I would call kind of standalone diagnoses of major depressive disorder and generalized anxiety disorder or social anxiety disorder. Whereas, most kids with depression will endorse some amount of anxiety. On some levels, when you're talking about pharmacologic treatment, the medicines you're using to treat depression are going to be very similar, if not the same medicines you're going to be used to treating anxiety. And so in that area, it's less important. That said, when you talk about the therapeutic approach to these kids, the types of therapy that are going to be effective for depressed patients can be a bit different than the types of therapy that are going to be effective for anxious patients. And so really understanding which of these diagnoses are kind of driving the bus per se is probably going to be really important. And for me, personally, I will just ask the question, when your depression gets better, do you find that your anxiety gets better? Or do you find that, they track together, or do they seem to track independently? And that can give you a little bit of a hint if you're kind of dealing with kind of two separate issues that might require a slightly more complex treatment regimen.
And given that one of your points last week is that one of the things that tended to potentiate the pharmacologic treatment of mood disorders is therapy, it's also great to have an ally who can help explore that with the patient as well.
Yeah, 100%. And, this is the same for every diagnosis, depression, anxiety. When you look at the literature, adding therapy onto your treatment plan is always going to lead to a statistically significantly higher response and results, in any study you look at. And so I just can't stress enough how important it is to try to have that plugged in. And then you do have a partner that you can really discuss the child's overall progress and treatment approach with.
Terrific. How about understanding ADD, ADHD existing with the mood disorder?
Yeah, this has always been an interesting one for me, because when you look at the diagnostic criteria for depression, you absolutely do get an overlap of, the ability to focus, the ability to concentrate, and severely depressed kids. In the adult world, we use the word pseudodementia, as kind of a label for the type of cognitive impairment severely depressed individuals can have. And in kids, you see it as well. Kids with really severe depression absolutely can have some of these symptoms. That said, on the flip side, when you look at ADHD, we oftentimes really focus on the hyperactivity, impulsivity piece or the inattentive piece. But you have to remember that, ADHD, one of the core symptom complexes we often see in these kids is they can tend to be pretty agitated and pretty irritable. And so if you approach the treatment of ADHD with just a stimulant medication, you might be missing the boat of a patient who might be struggling with depression, and vice versa. And I can't tell you the number of kids that I have seen that are just agitated and irritable, and I've just assumed really, and I probably maybe even initially wrote off some of the inattentiveness as being this kind of diagnostic picture with depression. And they just are not as responsive to the antidepressants as I would expect. And then when we've had a chance to take a step back and do a little bit more thorough look at things, we recognize, holy smokes, there really may be some untreated ADHD here. And boy, when you add a good evidence-based treatment for ADHD with these kids, the agitation just melts away. So it's quite impressive, because you wouldn't necessarily think your irritated, quote unquote, depressed patient would get better with a stimulant. But if it really is ADHD that's the underlying diagnosis that's driving things, you really do see that. And so from my standpoint, I think it's really important to look at what are the overlapping symptoms between diagnoses. And so with depression and ADHD, you're going to see that overlap in some focus and concentration issues. But if these kids are kind of low energy, not really wanting to get out and hang out with friends, their interest has really dropped, versus the kid who is agitated and irritable, but is also just kind of bouncing off the walls and a little more on the hyperactive side, looking at your symptom complexes and seeing which category is kind of a higher weight and focusing your treatment in that category first is probably going to be your best bet.
And given that there's not a molecular test like a strep screen, sometimes it just means keeping an open mind, right? If things aren't going the way you thought they were going to do, that you reconsider.
Yeah, and you've just touched on probably the biggest hurdle that we have in mental health and psychiatry, and that is the lack of biomarkers. And so we really are kind of left to these nosological approaches where we have clusters of symptoms. The important thing to understand is that, that open mind of saying, like, what am I missing? Like, is my treatment not working because it's not the right treatment? Or is my treatment not working because I'm not treating the right thing?
How about OCD?
Yeah, OCD is another one. Now this one tends to not show quite as much overlap with mood disorders, But I will say that patients with OCD and depression, one of the things to really try to understand is the depression the primary issue? Do they have a depression and a really significant OCD history? Or is this a kid who developed OCD and has struggled with it? And because of the burden of the illness, they've really developed some depressive symptoms over time. And so, each of those kids would take a slightly different approach. That said, again, there is some overlap in the treatments there, and treating underlying depressive symptoms can always help give kids more bandwidth and ability to approach the evidence-based treatments for OCD, which really are exposure therapies and things that tend to be pretty intense for them. And so you want to make sure that you're really on top of any underlying depressive disorders. But I have personally found a lot of kids especially with chronic mental health conditions like OCD and some of these other conditions, it can just really wear them down over time. And that depression, really is going to improve quite a bit as you improve the primary underlying diagnosis, such as OCD.
The next one is one that I think I've been conditioned to worry about missing, and that's bipolar disorder.
Yeah. And this is a really hard one in kids. And I think that the most important piece here is to really take another close look at the diagnostic criteria for a manic episode. And, if you look at that diagnostic criteria and you see things like, not sleeping super great or feeling impulsive or kind of being pressured and all of these energy things, you say yeah, that sounds like my kid, on any potential given day of the week. The deciding factor here is the time frame. And a manic episode really needs to be at least 1 week of these symptoms occurring most days, all day. And that is where you start to see, my kid is so manic, they must have bipolar, my kid's so bipolar. Well, when you really sit down and ask, well, what's the timing of this? It's like, well, that's, it's maybe when their stimulant wears off at night and they're bouncing all over the walls or things like that. So the bipolar disorder is actually not as common in kids as we probably think, based on just the idea that these manic symptoms we can actually see in kids pretty often. That said, it absolutely is there. And we do see kids that meet the criteria for manic episode, and absolutely, it's something we need to watch for. That said, you don't always have that history, right? And you may have a kid in the midst of a depressive episode, or maybe a kid that's just, hasn't quite had the full expression of those, bipolar symptoms. You start those kids on a medication that might be a little activating, you may very well provoke, some of those manic symptoms. So if you have a kid that you've started on an antidepressant and you're treating depression, and boy, they come back and they are just so much better, and they're feeling great, and boy, they're not sleeping, and oh boy, this is seeming like a little too much. You want to watch for those kids, because you absolutely can get kids that can get kind of provoked into one of those episodes with the use of serotonergic antidepressants or kind of those first line antidepressants without having some type of mood stabilization treatment on board. So I think the thing with bipolar is to beware not to overdiagnose, really focus on the time frame of those symptoms for mania, but also in the kids that it's not even on your radar. If you're treating a depressed kid and all of a sudden they're just acting real funny after you start their antidepressant, it's something to then maybe get a little closer history of. And the other thing with bipolar disorder is, really looking at the family history. Bipolar disorder is something that absolutely has a pretty heavy genetic predisposition. And so if you have first degree relatives with bipolar, it's something to be keeping an eye on. We
did a set of episodes a few years ago now about the importance of looking for trauma, but I think it always bears repeating the role of taking into consideration trauma that may be underlying some of the problems.
Yeah, you bet. It's the one kind of cross-diagnostic consideration that we always have to keep in mind. I was talking to a colleague of mine who's a trauma expert and works in the Intermountain system, but he was just talking about they were reviewing some of their outcomes data for the kids that they've collected across the institution. And, you see pretty similar rates of expression of underlying depressive diagnoses and that we would expect from an epidemiologic standpoint. And we know what the baseline rate of trauma is for kids. But the funny thing was, or not funny, but the really interesting thing was when they looked at the number of kids in this data set who actually had these diagnoses, the incidence of trauma was so much higher than what you just expect in the baseline population. And the takeaway from that is, if you're treating a kid with a mental health condition, you have to ask about trauma, because the likelihood of there being some sort of traumatic kind of history or contributor to the symptoms you're trying to treat is much higher than you would expect in your general population. And the reason why that is so important to know is that there are absolutely really good evidence-based approaches to helping with that. But if you don't know about it, again, another situation where you might be trying really hard to treat depression with an antidepressant and your kid's not getting any better. It may be because there is this history there that really needs another form of evidence-based treatment to address.
Neighboring concern, what about psychosocial factors complicating the process?
Yeah, this is probably I think the biggest confounder when we talk about treating depression. And that is because when we're utilizing medications, we are pretty firmly based in the biological aspects of depression. But we know that depression is a biological, psychological, social, spiritual disorder, and that any disruption in any of those categories can absolutely worsen those symptoms. And so, again, if you're trying your hardest to get the kid on the right antidepressant, and yet there is a psychological history of, again, those traumas, that's where we're talking about the psychological piece. The social piece of that really is what's going on in their life right now. Is this a kid who's maybe really struggling in school because they have an undiagnosed learning disorder? Or is this a kid who is in a family that's struggling with, tension in the parents, domestic violence, all sorts of factors that absolutely affect a child's well-being that may not be readily discussed. The more that we can kind of screen and ask about those types of questions, the better we're going to be able to tailor the treatment. If we have a kid who comes in with very, very high psychosocial burden, I'm not saying that an antidepressant isn't a potential help there, but you may be missing a pretty large opportunity to intervene in other areas if you're unaware of it.
All right, let's talk about something that probably is much complication of treatment. Well, both. Let's talk about the issue of self-medication. More of an issue in our older adolescent patients, but definitely something to consider. What do you see and what do you advise about patients who are self-medicating, often self-initiated with substance use of various kinds?
Yeah, it's these kids are at such a high risk, whether, pretty much any diagnosis across the board from mental health standpoint is going to be associated with higher risk of substance use. And part of the issue there is that these kids are in a state of dysphoria. They do not like the way they feel. And anything that can give them some relief from that, they're going to seek after it. And it turns out that a lot of these, substances that kids have access to fill that role for them. And so if they can get some escape from the discomfort or the pain that they're experiencing, they're going to gravitate towards those types of symptoms. Unfortunately, most of these agents have some interaction or at least interface with the serotonergic, dopaminergic systems of the brain. And so it gets really difficult to treat depression with our typical agents when you have coexisting substance use going on. Cannabis is a great example. The cannabis molecule to the brain looks very similar to the serotonin molecule. And so when you have these rapid influxes to what the brain looks like serotonin, it's going to actually produce more serotonin reuptake receptors. Well, when that cannabis is no longer in the system, all of a sudden you have all these serotonin vacuum cleaners sucking up all the good serotonin, and you can actually complicate and make depression worse. So, one of the discussions I have with every patient that is struggling with depression, especially teenagers who may, really have this idea that their use of cannabis is unrelated and it actually helps them. I have found the best approach with them is just education, just describing what I just explained about the serotonin system. I get a lot of kids who are like, oh, okay, yeah, I hadn't really thought about that. And I think especially with the older adolescents, just having an informed discussion, because I think the whole drugs are bad, at that point, they just kind of tune you out as another adult who doesn't necessarily know what they're talking about.
Well, I think it's more complicated too. I think with increased legalization that I think that access has changed. And I think the way substances look has changed. I think especially in the issue of cannabis, since, edibles frequently look like something you're going to get out trick-or-treating, that it feels more benign for somebody. And so they say it makes me feel better. And it looks like, something that is tasty and delicious.
Yeah. And with that, with the commercialization of this, the potency of these products compared to what people used to get on the corner 10 15 years ago, it's just completely changed. And so we're seeing kids that are having 10 times the potency of these drugs than what they've seen historically. So it's a major issue that we have to keep a close eye on.
Let's talk about something else that I think seems to me to be increasing in usage, and that's easily available things like CBD and kratom.
Yeah. And it's one of these things that because they're quote unquote legal, people assume that they're quote unquote safe. And, kratom's a great example. Kratom has such an impact on the opiate system that, we absolutely see, dependence and, addictive problems with kratom. And I think the takeaway there is this stuff is accessible. This stuff you can get in, the smoke shop on the corner. And so making sure that we're screening and asking about it with kids, because again, kids don't necessarily think of these things as illicit substances because they're illegal. And that must mean that they're perfectly safe.
Somebody down at the government said this should be just fine, young man.
Right, exactly.
What about nutraceuticals? Do you see that being an issue?
It can be. I'm personally of the opinion that kids and families, suffering with depressive illness, they should have access to just about anything that might potentially give them some help. And so we have a lot of agents that we have evidence for, lots of studies that can kind of guide us whether these things work better or worse. My experience is that most of the nutraceuticals, lack some of that same evidence. Now some of these things like omega-3, things that are considered, have been considered nutraceuticals in the past, like they have good evidence that we use them in mainline psychiatry. The stuff that just doesn't have the evidence, if it's because the evidence just hasn't been collected, a lack of evidence is not necessarily negative studies, but it means that you really then have to always find that balance of risk and benefit. Where you don't really have a good idea to quantify what the benefit might be, the risk really then becomes the deciding factor. And so for me, if it's something that can potentially cause harm, that's where you have to really take a step back and say, well, is this really worth it, given the fact that we're not really sure that the benefit's there? There's so much of this stuff out there that is pretty benign. And again, at that point, if it's, something that you feel from a standpoint is not necessarily posing a particular risk in some other way, from my opinion, I again, as long as it's safe, I have no problem with people trying things. I just want to know what it is and what's in it, because you can also see cross reactivity with a lot of the medications we use with these nutraceuticals. The trick is being able to understand what they are, because there's a lot of them out there.
A lot of them out there, and given that they're not regulated by the FDA, there are a lot of studies that show that what you think you're getting isn't necessarily what you're getting, which is unfortunate. And also in a situation where the margin between the medication and placebo isn't often really wide. I guess one of the things I worry about sometimes is people spending a lot of money for something that may be, as I've often said, you're on Placebo XL.
Yep. And I consider the financial piece with a lot of treatments in mental health. I mean, there are centers out there where you can send kids to get full functional MRI studies and quantitative EEGs and all of these things for which there's very little evidence for. And the families will be out thousands of dollars. To me, the financial piece is a risk that really needs to be considered in these decisions. Right,
because parents will, we're wired to do anything we possibly can for our kids.
You bet.
Let's talk about just a couple more things. What about, I think we can say that neither one of us approves of, I tried my medications on my kids. What do you think of that?
Yeah, I'd say that's probably not the best approach. I will say, though, there's something hidden there. And we talked about this last week. And that's, when you do have a first degree family member who responds particularly well to an agent, say an antidepressant, I think that is, important information as you're looking at potential medications to be prescribing the child. Let's just, get them their own prescription.
Sure. And try to approach it systematically.
You bet.
Medication side effects can present like mood disorders sometimes.
Yeah, you bet. Just what we were talking about earlier, if you have a severely depressed patient and you start them on a serotonergic agent and all of a sudden they come in not sleeping for days, you may have provoked a bit of a manic episode. So these medications are not without side effect profiles that have to be, really monitored closely.
Some neurologic diseases can look like psychiatric diseases.
Yeah. And I think the takeaway there is, anytime you have especially a more complex presentation, a patient who is depressed, who maybe is sleeping so much that they're just, really withdrawing. Maybe they're not, talking as much, they just seem a little sluggish. Boy, there's all sorts of degenerative neurologic conditions that can mimic that. Catatonia is a symptom that crosses these categories. Neurologic illnesses can provoke it. Depression can provoke it. So I think keeping a multi-specialty approach to diagnosis is always going to be important.
And of course, people who have chronic disease of any kind may have depression, may have reactive symptoms related to that.
You bet. And we touched on this a little bit earlier. We're talking about the burden of illnesses like OCD and things like that. I think some of the most stoic yet struggling kids I work with are kids with these chronic medical conditions. And I think the importance to know is the incidence of depression in these diagnoses is higher. And some of that has to do with reactivity, but some of that does have to do with physiology. And so we know that treating depression in pretty much any of these chronic medical illnesses is going to increase the likelihood of a good outcome of your medical treatments as well. So, treating the whole kid, always a great idea.
And when you talk about treatment of depression there, you're talking about both pharmacologic treatment as well as therapy.
You bet. You're never going to hear me separate those two. Got to have it all.
I will take that for granted. All right, Jeremy, thank you so much. You covered a lot of ground as usual, and it's going to take some digesting, but very, very helpful. You willing to talk to us again next week?
You bet. I'll look forward to it.
You want to mention the call-up line again?
Yeah, thanks for the plug. Again, one of the things that we know are, in managing these kids, they can be really hard. And sometimes having somebody to bounce ideas off can be really important. So the call-up line is a state-funded consultation line available to any primary care provider, pediatrician in the state. The phone number for that, you can call this Monday through Friday from 12 to 4:30. And the number is 801-587-3636. And you can just call and have pretty much immediate access to a child psychiatrist to discuss any case, any question you have related to these things. And then heading into the new year, we're going to be expanding our hours. We're going to be expanding the services we offer. So please give us a call. We're really wanting to engage with our primary care colleagues out there. We know you're dealing with the brunt of the mental health burden in the state. And so let us help you any way we can.
Additional feature that I've used before, and that's that you talked about hoping to get some asynchronous communication. But one of the things that I found is that I can call and make an appointment to talk to someone, which is nice because that way we can blend my chaos with your chaos and try to find a sweet spot.
Yep, we're trying to be as flexible as possible. We know how busy providers are during the day. So anything we can do to connect, we're willing to work with you.
Terrific. Thank you very much. And we'll look forward to talking to you next week.
Okay, see you soon.
Thanks, Jeremy. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.